Good morning, everybody. Thanks for coming. Today's surgery grand rounds on the medicine grand rounds day, as everybody knows. So it's my pleasure to introduce somebody everybody knows. Dr. Michael Ritchie is going to give us our grand rounds presentation today on renal sparing approaches to childhood tumors. Everybody kind of thinks they know a lot about Mike, but I thought I'd spend maybe a minute or two just kind of talking about the things he's done outside of PCH. So some of the highlights that I would think if I was him, and I'm certainly not trying to speak for him, but Mike has been very active in, I think, all three areas of what we would consider medical specialty, meaning research, education, and clinical care. Obviously, we all know him as a really busy urologic surgeon, a technical wizard, and somebody you can always call to for any time we need help or a question to be answered. But he's done a lot of other things. So on the academic side, Mike has served at the American Board of Urology level as well as the American Board of Medical Specialty levels at the highest level. So he was the chair he's the president of the American Board of Urology in 2014 and 15, and then the past president for 15 and 16. And he's functioned at that level for at least 20, well, not the presidential level, but within the American Board of Urology for almost 2 decades. And then on the American Board of Medical Specialty, which is the board that sits over all the other boards, he's also functioned at a high level there, including part of MOC, of which he was just named the co-chair of the maintenance of certification, although I'm not sure they're still calling it maintenance of certification. They do, yeah. So he is going to be co-chairing that committee for 2 years, Mike? Yeah. So that means that all of how we decide, we being all the other medical specialists, whether it be surgery, pediatrics, critical care, how we decide maintenance of certification is going to be proctored, so to speak, how it's going to be controlled is really going to have to filter back up to the chairs of the American Board of Medical Specialties. So those two positions have obviously brought a lot of experience and wealth of information to him, and hopefully he'll be able to bring that back to PCH as he continues his role there. And then on the academic side, or the research side, if you ever get a chance to peruse his CV, he's written 50 book chapters, and he has over 180 peer-reviewed publications. He trained at a very academic place in Michigan and spent some time in the Air Force, and then we were lucky to have him come here in 2015, and you think he came to a non-academic place, even though we're trying to change the culture of that quote-unquote academic nature of what Phoenix Children's Hospital is. Mike has continued to push that envelope forward, and he just told me he's just finishing another book chapter with Bob Schamberger, who, if anybody, all the surgeons in the room know Bob, he's the surgeon chief and chair of the Department of Surgery at Boston Children's Hospital. So, Mike, thank you for giving grand rounds today, and we look forward to hearing what's new in renal sparing surgery. So.
All right, thank you, Dan. And it's always nice to give a talk on a topic that you're passionate about, and I'm going to talk a lot about Wilms tumor, which is what I've spent my career doing a lot of studies and research on. I was very fortunate as a fellow at the Mayo Clinic in Rochester to work with urologist Dr. Panos Kalalis, who was on the National Wilms Tumor Study Committee at the time, and I actually succeeded him in that role as the urologist in the committee, and so that led to my interest in this field for a long time. I thought I'd expand it a bit, not just talk about Wilms tumor. I'll touch on a few other areas where we see lesions in the kidney that do affect the kidney and need treatment, and we'll talk about management of those as well. So if I can get the slide to advance. All right. Yeah. It's frozen. Technical guru from the back again. Is the ED guy back there? Okay. Technical problems over. So the topics I'm going to talk about today, I've kind of broke down arbitrarily into benign and malignant, but recognizing that some of the benign things we talk about have the potential to have some lower risk for malignancy. And I'll talk about the way in which we can go about thinking about how to preserve kidneys and kidney function. So first area, renal cysts. Renal cysts actually are more common, at least in our practice, in the number of referrals we see than they used to be when I started. Imaging has changed a lot over the years, and we find a lot of incidental things. The incidence of renal cysts in children is reported between 0.2 and 0.5%. The natural history is most of these don't change over time. Some do get a little larger. The ones that are diagnosed prenatally or right at birth sometimes will disappear, and these tend to be cystic segments, dysplastic segments of the kidney, and they'll involute and go away. But very few cysts overall require intervention. In the adult world, they created a classification of renal cysts to kind of strategize how you would think about managing these and putting them in different risk categories. And the Bosniak classification has been around a while. So most of the ones we see in kids are 1s and 2s, and that's true probably for adults as well. Where we get to be a little concerned is the ones that are a higher grade, the grade 3s and 4s. Now 4s are what we would look at, the imaging go, that's a cancer, it's got some cystic components. 3s are sort of in between. In the adult world where cancer is more common, the grade 3s tend to have a 50% risk of malignancy. We don't really know what the risk is in children at this point. There's very limited publications and studies on this in children. This paper was from Toronto a number of years ago, and what they looked at was all their patients with complex cysts, and they defined that as grade 2 or higher. And again, for me with grade 2s, I don't worry too much about those. So the vast majority of the patients in this review were grade 2. There was no, this is retrospective, this wasn't a prospective evaluation, so arbitrarily some patients got surgery, so 5 of their nearly 40 patients had an operation. 2 ended up having a malignancy, and one was a Bosniak 3 and one was a Bosniak 4. So again, it does tell you that the Bosniak 3s do have some risk for malignancy, and I'll show you a case that we had here. But most of the patients remained stable, but again, most of these patients were stage 2. So the grade 3 cyst, this would be one that would be a little concerning when we get it. We don't know what this could be, but there's multiple cysts and then these thickened septa with some enhancement between the cysts. So in this circumstance, you'd have to say, well, is this a malignancy or not? Unfortunately, I think a lot of times we look at some of these and say, it's probably not malignant, but I just don't feel comfortable watching it, and the parents get a little nervous when you go over the options with them, and so a lot of them choose to have these removed. Fortunately for these, it's probably first and foremost for us, we're thinking we're going to spare the kidney, and we'll go in and take it out and actually preserve most of the kidney that's there. Well, this is a case where the cyst, was also would call a grade 3, but there was a little more component where it was a little thicker and almost like a little mass within the kidney. This child turned out to have medullary renal cell carcinoma, and actually because of the size and location in this one, we didn't try and do renal sparing. We actually had gone and done nephrectomy. But as many of you know, with this disease, the outcome is poor, and was so in this case as well. And here's just another case, again, of the Bosniak 3, again, septa. And this one turned out to be just simple segmental cystic dysplasia, just multiple cysts next to each other. And we took it out, kid did fine, no problems. So I think what we need, and we will hopefully have soon going forward, is a multi-center prospective study looking at these higher cystic lesions. There's an oncology working group in the Society of Pediatric Urology, which I'm soon going to be president of, and I've been a member of that committee for many years, and they're going to get a multi-center study, IRB controlled, to look at these lesions. And I think given the rarity of most of these, I think we need probably at least 20 or 30 children's hospitals involved to collect this data to get meaningful information. So it'll be a while, but we'll get there someday. The next lesion I want to talk about, glad to see Francis is here, he sees a lot of these kids with me, is angiomyolipoma. And in the pediatric population, these are invariably associated with tuberous sclerosis. In the adult world, you'll see these idiopathic AMLs that'll occur primarily in women. But in tuberous sclerosis, it's very common to see AMLs. About 80% of the patients will develop them, and they usually are multiple and often bilateral. They tend to occur in the first decade of life, but they really start to enlarge and grow more rapidly when you get to be a teenager or a young adult. And what we're really concerned about are two things with this lesion. One is risk of bleeding, and the bleeding tends to occur when the lesions are larger. Historically, and in most of the literature, it states that if they're greater than 4 centimeters, that's when the risk of bleeding becomes high enough that you should consider intervention. Some more recent publications trying to move this up a bit, maybe make it 5 or 6 centimeters, but somewhere greater than 4 centimeters, you really need to start thinking about intervening. Most of the lesions that are greater than 4 centimeters do tend to occur in postpubertal patients. You don't see them much in younger patients. The other main concern with these lesions in tuberous sclerosis is the impact on renal function, and I'll show you some slides that can make it obvious why it can be a problem, but they just compress and destroy the normal renal parenchyma that's there when they get to be larger and larger, particularly if they're multiple. Now, when I started in urology, the only modality we really had for treating these was surgical removal, and it was not an easy surgery. Embolization became very popular with interventional radiology going in and just putting a little coil or something in there to block off the blood supply to the lesion. Although some of these, even though they're big, really aren't that vascular, but most of them are very vascular. Cryotherapy has also been used, and they were mainly used to prevent bleeding. That was the real impact that we had with those. But what we noted over time, with more and more data accrued from following patients that had these interventions, is that it can affect kidney function because you're not only embolizing just the lesion, you often get some scatter effect and embolize some normal tissue. Plus, recurrence rates are high. Whether it's surgery or these embolization techniques, you'll see more and new lesions develop. So you're just treating one focus and not the entire problem with the patient. So, this is how they initially are seen on ultrasound. They're just an echogenic focus, very bright, and, this is a very small lesion. We wouldn't treat this. If we needed to, it'd be easy because it's small, but we'd leave these be. But then, in some patients that don't get adequate follow-up and care and don't get the treatments we have available now, you'll get these massive tumors that are just replacing the kidney, and kidney function can be very poor in some of these patients. And so that's what we're trying to really preserve and prevent. So we're fortunate we have a new treatment modality, and that's the mTOR inhibitors, to try and systemically treat lesions in these patients. So we're not just treating the kidney, they treat lesions in other parts of the body, the brain, et cetera. Now, with this drug, we see pretty significant reduction in volume in a fair percentage of patients. Not everybody, but even the ones that don't get a reduction often will stabilize, so they don't keep growing. And, although we need more and more data, it seems like we're limiting the risk of bleeding, because at least on the prospective studies, they really haven't seen problems of bleeding on patients on the drug. More importantly, the prospective studies have shown that renal function is being maintained on these patients, which is important. And lastly, we have noted that you really probably need to keep treating them. It's hard to decide if you can withdraw the therapy, because if you do, you'll see regrowth and then have to get started again. So, we'll continue to learn more from these studies that are being done, but I think it's been a very effective treatment, and it certainly has kept my hands off these kidneys, which is a good thing. Next lesion, moving to what we would term malignant lesions, is renal cell carcinoma. And just going back to angiomyolipoma, tuberous sclerosis patients can get renal cell as well, and oncocytomas. I've treated about 5 of those through my career. So you can't always assume it's an AML, and sometimes if you look at the imaging and it's not characteristic, you got to biopsy the lesion to see what you're treating. Now, with renal cell, it's something we don't see a lot. It's the most common malignancy of the kidney in the second decade of life, but we just see a handful, here. The primary treatment for renal cell, both in kids and in adults, is surgical treatment. Unlike with Wilms tumors, we'll talk about a bit more, we have effective adjuvant therapy to try and treat the tumor. They're certainly looking at other newer therapies. Immunotherapy is the most promising for a lot of solid malignancies now, but it's not quite ready for prime time, but I think that it probably will be before long. Overall survival is about 50% in the older series, and it's really stage dependent. If you've got a low stage tumor, stage 1, you can take everything out, outcome's going to be much better. Now, the concept of doing nephron sparing surgery for renal cell carcinoma has actually been around for a while. It started at the Cleveland Clinic. Andy Novick, who was the past chair there, did a number of surgeries over a long period of time, because at the time he introduced this, it was kind of heresy. I was like, you can't do this. This is a cancer. You got to do a radical procedure. You got to take it out, or else you're going to have a bad outcome. But he persisted. He was very selective in his approach and was working with smaller tumors and reported very good outcomes. So then, as time has gone along, this has become commonplace throughout the country. I know at Mayo Clinic, they probably treat 240 of these a year, the way things go now. But one of the problems we see is that they probably are treating a lot of tumors that weren't even diagnosed back in the 60s and 70s. A lot of small lesions are found on imaging these days, incidentally, and the real question right now is whether they need to be treated at all, and that's what the adult community is struggling with a bit. But there are centers that are doing prospective observation of some of these small lesions instead of removing them. But the one thing that they have done in the adult business with a renal cell is to then develop really good techniques. These are done primarily with the robotic laparoscopic approach. But these guys are very good at doing this, and they can take even larger tumors out more safely. Now, there is a classification to try and grade these tumors, or kind of have a sense of which ones are more amenable to partial nephrectomy, and it's called the renal nephrometry score. It has to do with size and location within the kidney. And it's a complicated scoring system. I'm not going to review it, but basically, the lower number of points you have, the more amenable it is to doing a partial renal sparing approach. And you can actually apply this to Wilms tumor, which we see more commonly. And there's been a paper from Nick Collis in Colorado that's looked at this. And it's kind of common sense to me. I mean, you got a small lesion here in the lower pole, so this is below the midplane of the kidney. It's more, not quite exophytic, but it doesn't extend deep into the sinus here, as compared to this one, which is a centrally located lesion going right into the sinus. Well, this one, we know it's a pretty easy partial nephrectomy. This one, for a renal cell, would be problematic, although I know that at Mayo Clinic they would do some of these. But it's, with Wilms tumor, it's a little different. Our thinking expands a bit in terms of location and size, because we can treat these with adjuvant therapy. So if we have a residual margin, or if they're a little bit too big to start with, we give them chemotherapy, make them smaller, so we can treat these a little differently. So now I want to go on to Wilms tumor and renal sparing approaches. The first partial nephrectomy for Wilms tumor was done in 1954, the year I was born. And this was done by Dr. Rickham in England. So it was a bilateral patient, which is where most of these are done still today. And so he did a nephrectomy and did a partial nephrectomy on the other side. Now, prior to this time, and even after this, I mean, most patients with bilateral Wilms tumor, if they could, preserve part of a kidney, they would use radiation to try and shrink the tumor, or do a renal sparing approach that way. But the radiation obviously is very bad for the kidney tissue and kidney function. So it wasn't a great thing, but it was pretty much all they had up to that point. But this patient did live 10 years after the procedure, so that was notable. The barriers for employing partial nephrectomy Wilms tumor, I mean, there were several, and I'll review these individually. Diagnostic capability was one. Back in the 50s, imaging was pretty limited. Surgical techniques, they've improved a bit, and I think particularly now, as I've explained with renal cell carcinoma, I think we have a lot of different things available to us. I think one of the biggest problems with Wilms tumor in particular, given that the number of these patients is small at each center, is experience. I mean, it really takes some experience to be able to tackle some of these cases, and people, sometimes are a little hesitant to do that. And I think, when I'll review with you, when I look at the national Wilms tumor study experience over the years, I think a lot of people got nephrectomies that probably nowadays hopefully will not. But again, the beauty of Wilms tumor is we have effective adjuvant therapy now, which they did not have in the 50s. I mean, chemotherapy for Wilms tumor didn't really evolve until the 60s. So going through pre-op evaluation, I mean, think about, we didn't even have imaging at the beginning of the 1900s. IVP was the first modality used to image the kidney. Ultrasound wasn't around to the 60s, and if, like me, you've been around a long time. I remember ultrasounds in the mid-70s, and I wouldn't feel comfortable making a diagnosis of anything on those. I mean, I could see hydronephrosis, but that was about it. CT didn't come around to the 1970s. The first commercially available unit was developed in England by Sir Godfrey Hounsfield. He's known for the Hounsfield units, which we use to look at tumors and what they are. And he did this at EMI Research. Who knows what EMI was important for in the 1970s besides the CT scanner? Beatles. The Beatles records with EMI. I know Dean Smith knows this. Some people think John Lennon funded the CT scanner. I don't know. But anyway, so, these are relatively new inventions, for, again, some of us who've been around a long time. So I just put this up for historical interest. This is an IVP. Probably half of you haven't even seen an IVP ever. I can't remember the last time I ordered one. Louis, you remember the last time you ordered one? So we don't use this, but if you had this as your only imaging for a bilateral Wilms tumor, you could see that, there's a mass here and the collecting system splayed out. So yeah, you got a tumor here, but you wouldn't even know if there was a tumor on that side. And back in the day when we operated these patients, we had to explore the other side to look for tumors because we might have missed them on imaging. We no longer need to do that because of our better imaging modalities. So when we consider doing nephron-sparing surgery for these patients, we have to weigh the risk versus benefit. So the benefit would be to decrease the incidence of chronic kidney disease, renal failure, You could say decreased risk of hypertension. That's not followed as carefully in the literature. And then risk, for most patients with Wilms tumor that are going to have partial nephrectomy, except for a select group, you probably need pre-op therapy for most of them to shrink them down to make it feasible. You have to look at increased morbidity of treatment, but that's not too big of a problem from the surgical standpoint. But the oncology perspective is we have to make sure we have complete tumor removal, because if we don't, we increase the risk for recurrence and risk for mortality. And you could look at risk of late effects of treatment if you have to give more therapy because of incomplete removal, and I'll address that in a little bit here. So I got interested in this a long time ago, and we did a review of the NWTS 1 through 4 studies back in the mid-90s, and we started to look at renal failure. It had been part of the late effect study, but not, really a focus of it at the time. And we looked at what the rate of renal failure was from the retrospective chart review. Now, keep in mind, this was part of the late effects review, but was not part of the actual study, so data points are a little bit more incomplete. But we had data on thousands of patients. And what we noted was that overall the risk of end-stage renal disease in patients with unilateral tumors was overall low. At 16 years of follow-up, it was 0.6%. Not inconsequential, but much lower than we saw with the bilateral patients. And that would be expected, because with the bilateral patients, they have disease in both kidneys and might risk having more kidney tissue removed, leading to renal failure. Now, the types or the categories of renal failure, we kind of broke down into two areas. One was progressive bilateral Wilms tumor leading to bilateral nephrectomy. That was by far the most common cause of end-stage renal disease in patients with bilateral tumor. The other category is chronic kidney disease, which our nephrologists treat all the time. And you could break it down into several categories. Injury to the kidney from the treatment. Chemotherapy somewhat, radiation more so back in the early days. The use of radiation, being able to focus it to a specific area, lowering the dosage, has really impacted a lot. So we don't see much radiation-induced injury now for unilateral disease, and less so for bilateral because of our treatment approach in that as well. One thing we recognize in this review, and I'll expand on this, is nephropathy associated with certain syndromes predisposed to the formation of Wilms tumor, and we recognize that those patients have a predisposition to having renal insufficiency. And the one category which we really have a hard time assigning the renal failure to is what we would term hyperfiltration injury. Dr. Arguelles and I both did studies on this when we were fellows at Mayo Clinic looking at solitary kidneys, and there was a big concern back 20 plus years ago that we would see more and more renal failure, because if you have less than one kidney remaining, so if you have much less than one kidney remaining, over time that increased workload in the kidney is going to lead to renal failure. And it does happen, no question. Animal studies are clear on it. But in Wilms tumor, we really have a hard time assigning the category or the diagnosis to this in many cases, because of all the other confounding variables that could cause injury to the kidney. Plus, we don't have the granular data on the national study level to really identify that. Only single institutions do, but they have small numbers of patients. So if you look at the syndromic patients, which I mentioned, I mean, it was clear that certain categories were at high risk for renal failure. The one with the highest rate is the Dennis-Drash syndrome, and we actually had a patient Dr. Molitor operated on yesterday at this hospital with that. And these patients have a high risk for tumor, but very high risk for having renal failure. I'll explain why they do. The other group that we identified in this review back in 2000 was patients with aniridia, and then also patients that just had genitourinary anomalies like hypospadias and then developed a Wilms tumor. So their rate of renal failure was far higher than the unilateral patients without syndromes, and so they really needed to be addressed. Now, if we look at why they get this, the Dennis-Drash patients have a mutation of the WT1 gene, and the aniridia syndrome patients have a deletion of WT1. And for some reason, the mutation seems to injure the kidney more. They get a very specific nephropathy, it's mesangial sclerosis. But these patients need to be followed closely, and particularly in the Dennis-Drash, if they go to renal failure, we tend to want to take their kidneys out because of this tumor risk that's there, and the kidneys aren't serving them any purpose. But the GU anomaly still, there's a risk there for renal insufficiency. So it's good that we identify this to consult patients for their follow-up and when they go through late effects clinics, so they know they're being screened very carefully. So after about 15 years after our initial report, we decided to again look at renal failure with longer follow-up and more patients. This was after NWTS 5 was finishing up. In this particular review, we didn't include the patients with syndrome because we knew that they had a much increased risk. We really wanted to look at the rest of the patients and see what the risks were. So the follow-up, although this was a longer look than our initial paper, is still relatively short. I just want to mention that. The median follow-up was 14 years. The other concern I have, and this is always going to be a problem, is that at 20 years, the number of patients, so we started out with over 8,000 and we're down to 2,000. So, we need to follow all these patients much longer to really identify the risk at 40 and 50 years, because that's where we worry about that hyperfiltration, late renal failure that could develop. But I think, now we recognize this is one of the risks of treatment of this disease, so all of our late effects clinics, survivor clinics are looking at this and monitoring these patients carefully, and so the Children's Cancer Survivor Study is going to report on this better than the NWTS could have in the day. But when we looked at this group, we had 100 cases of end-stage renal disease and kind of 50-50 between progressive bilateral Wilms tumor and the chronic renal failure. But the overall pattern with unilateral still was relatively low risk of renal failure. It was 0.7% as opposed to 0.6 in our prior review. But the bilateral tumors still had a fairly substantial risk, and it was highest for the metachronous tumors. So they had a tumor in one kidney, that kidney was removed, they come back 5 years later with a tumor in the other kidney, so you're working with the one kidney left and you're treating, and so you're going to see more risk of renal failure. Most anephric cases occur pretty early, so we just fail to satisfactorily treat the tumor with chemo and surgery, so the kidneys get removed because of that. Now, I just put this one slide up, and this is a single institution study. This actually comes from St. Jude's, where we can look more carefully at the patients in terms of what their risk to the renal function is. You can actually look at their GFR, as opposed to I'm looking at end-stage renal disease, and we can kind of track that pretty carefully on a population level because Medicare reporting data and all the information for patients on dialysis, transplant, we get that. But in this study from St. Jude's, they looked at patients exclusively that had a unilateral tumor removed without radiation. Let's make that point. And then they had a pretty good follow-up. So the median, this is almost 20 years, range up to 30 years. And for the most part, these patients are doing relatively well. Some of them obviously do have some reduced function. You take one kidney out, you'd expect that. But complications, of like hypertension were low, only 3 patients on treatment. So that's encouraging. There are some other single institution reports that suggest a little higher risk, but I think this one is probably one of the better done single institution reports and pretty sizable. So if we want to do nephron sparing surgery, who are we going to do it on? Well, obviously, as I've shown you, the data on bilateral Wilms tumor patients is clear they need to be included in that group because their risk of renal failure is the highest. With the unilateral Wilms tumor, I think those patients we know have an increased risk for bilateral disease probably should also be considered. And these are small numbers of patients. So these include some of our syndromic patients, particularly the Beckwith-Wiedemann hemihypertrophy. And as I'll show you in a minute, these are an ideal cohort to consider renal sparing surgery because we are screening them up front and finding small tumors at diagnosis. Now, what's unclear is that infants that have a nephrogenic rest, should they be treated differently? But you really don't know that sometimes, so the kidney's already out. So again, not something we can look at too much unless the imaging gets better to identify those. And then we look at the patients we know have an increased risk of renal failure. So the aniridia patients, again, would come up. Patients with GU anomalies, I think it's a consideration. But again, small numbers of patients. Solitary kidney is obvious because you only have one kidney left. You want to make sure you spare it. And then the open-ended question is, should you do it just whenever it's feasible? So anybody that comes in with a unilateral Wilms tumor, if it's a small lesion, should you treat it? And if you're in Europe, the SIOP studies, you're giving pre-op therapy to all of them. If it shrinks pretty well, should you do renal sparing surgery for them? And we'll address that. So bilateral Wilms tumor has been reported from MDTS with each study that was completed. And so going back, even in the early 70s, it was clear that people were thinking about how to spare the kidneys and using pre-op chemotherapy. So in that study, and this is all retrospective, all the NWTS studies and all the data I'll report to you, it's all retrospective. And what they did was, they just looked at patients who had biopsy versus upfront surgery, and survival was comparable. So they said, okay, survival's good, so maybe that should be our strategy. But even though they published and disseminated this information, it really didn't become the standard. If you look at NWTS 2 and 3, again, 50-50, treating with initial surgery and primary resection. And then you have to wonder that the patients at primary resection, probably have more favorable smaller tumors that led the surgeon to choose that approach. We don't know because, again, it's retrospective. But the one thing that struck me when I was going back and looking at NWT's data over the years is that although they reported as no significant survival in both papers from these studies, the absolute percent survival was or did appear to be lower for pre-op chemotherapy. But again, since you have a small number of patients, when you do the statistics, you can't prove that there's a difference. But when we went to develop the Children's Oncology Group studies after NWTS had closed, we went back and looked at the data for the studies and looked at long-term outcomes. And it really struck us that we were having a significant problem with survival in bilateral Wilms tumor. For NWTS4, the 10-year relapse-free survival was only 65%. And in 5, the 4-year relapse-free survival was 61%. And compare that to stage 1 favorable histology, which is above 90%. So we felt we could do better than this. And one of the reasons we were seeing poor outcomes when we did this long look back was with bilateral Wilms tumor, you tend to see more later recurrences and deaths than you do with unilateral disease. So we tried to identify those factors we felt were contributing to this decreased survival. One was clear to me was delay in local control. Patients were getting treated forever and ever and ever, trying to get the tumor to get smaller so they could maybe go in and do a renal sparing procedure. And patients got treated for, I'll show you, for a very long time. The next thing we noted was there was an increased incidence of anaplesia in this cohort. Anaplesia is one of the histologies that has a very poor outcome. It's not responsive to chemo. If you take it all out, stage 1, they do okay, but if it's not stage 1, then their outcome is worse. We were concerned about undertreatment, partly from inadequate staging. That's always been a concern with pre-op chemotherapy. I think we've had some ways to mitigate that risk and risk adjust treatment after chemotherapy to prevent this being a problem. But in NWTS, we certainly weren't using what SIOP had knowledge they've accrued about treatment of these patients. And then incomplete resection is always a concern when you do partial nephrectomy approaches and leaving positive margins and getting recurrence. Now, how long should you use pre-op chemotherapy? What's the optimum time before you should say, okay, it's time to go and operate? Well, we really weren't sure. In SIOP, and this is data on unilateral patients from SIOP 9, they randomized patients from 4 to 6 weeks of therapy, 4 to 8 weeks with the chemotherapy, and didn't find a significant difference in terms of whether it made a difference whether you went to surgery and the outcomes after surgery for unilateral disease. So they now standardly use 4 weeks. But if you look at it, they did see an improved reduction, so they had continued response. And the Germans, as part of the subgroup of SIOP, looked at their bilateral patients. We had a meeting with them in London a number of years ago when we were designing these studies, and Norbert Graff showed data that at 12 weeks in the bilateral patients, they didn't see any further reduction. And so that was, I think, this is the absolute cutoff. At 12 weeks, we should definitely go do surgery. Doesn't mean you can't do it sooner. As soon as you get a good enough response, if you think you can do an easy partial nephrectomy for a bilateral patient, you can do so. But 12 weeks, after that point, you're probably not going to have any benefit. Now, the staging I mentioned is a problem. And when we looked at the NWTS4 group of patients, and patients that had a biopsy done initially, not just treated with chemo without a biopsy, none of the patients ever had lymph nodes sampled, biopsied, or diagnosed as being positive. And we know that they were there. So we were understaging patients. And again, I'm not too concerned about that in terms of overall outcomes for most of these patients. The main concern we had was the rate of anaplesia. So it was 10% versus about 5% for unilateral patients. And most of these patients had prolonged courses of chemotherapy. The median chemotherapy in the anaplastic patients that had a misdiagnosis was greater than 300 days. So they went almost a year given therapy. And the reason they did it, they would start out with 2 drugs, didn't respond, then they'd go to 3 drugs, maybe 4 drugs, then they'd give radiation. They kept trying different things to get a response, and then finally said, okay, it's not responding, we have to operate. So overall, for the whole group of patients, the median elapsed days to surgery was 150 days, so a fairly long period of time. So I'm just going to show you this case. So this is a patient who had 12 weeks of chemotherapy, and you can see on the CT, you still have very large masses. But I can tell you, this isn't going to get any smaller. In fact, if anything, once it gets to a certain point, it's going to start to grow again. We took this tumor out. It only had about a 25% reduction in size, but these were stromal predominant tumors, very firm tumors. But you can go in and shell these out. It doesn't look like there's a lot of kidney there, but I just put up one representative slide. But this is a post-op CT on a patient that has these large tumors removed. The kidney's all just pushed away. You take the tumors out, and you preserve a lot of kidney function. So this is, why we feel like, at some point you just have to say, okay, it's time to operate. You're not going to do anything else. And I'll talk about our protocol that we had through COG that was recently completed and how we use the imaging to guide our therapy. This is a case that Lisa McMahon recently had here, and I just wanted to point out that not only can you get tumors small enough to do a partial, but these two tumors were treated, and there was really nothing left. There's a little shadow here that was left. Turned out these were actually probably perilobar nephrogenic rest, but they kind of look like tumors, but they respond very well to therapy, so this kid just had a biopsy of this and nothing else. So we were able to preserve all the kidney on that side, for sure, with effective preoperative therapy. So I want to just talk a little bit about unilateral Wilms tumor and the role for partial nephrectomy in that group. And basically, it's two groups of patients. For at least us, since we don't routinely use preoperative therapy, although we can choose to do so for select cases, we can find small tumors at screening and do renal sparing surgery very easily for a lot of those patients. But after preoperative chemotherapy is when you have the best bang for the buck to get more patients amenable to treatment. Now, I mentioned the syndromic patients earlier, so Beckwith-Wiedemann, aniridia, hemihypertrophy. These patients have about a 5% risk for Wilms tumor development. So they are recommended to have screening with ultrasound at 3 to 4 month intervals. And by doing so, you can find small lesions. Now, no one's ever shown that it improves survival, but it definitely can help you to do renal sparing surgery by getting to these sooner. And you have to do frequent screening, because I've seen cases where you went 9, 10 months and you got a 10 centimeter tumor. They grow very rapidly once they get past a certain size. So these are just a few lesions. So this would be a peripheral lesion, and I just put a piece of the ultrasound image here, CT scan of another one here, MRI of another image here. And so these are very easy to remove. Now, are these nephrogenic rest or tumor? You don't know from the imaging. Smaller size, maybe just their nephrogenic rest, but you want to go in and remove them. The beauty here is it's a small lesion, so it falls in that tiny tumor category. It's definitely less than 500 grams, but necessarily the age might be older because these have been screened for a while. But in any event, you take this out, and you might be able to just monitor these without chemotherapy at all. Now, the risk of recurrence is probably higher because they probably have other nephrogenic rest that might enlarge. But again, easy to remove them when they're picked up smaller and preserving most of the kidney. So these patients are clearly amenable to that approach, and they were part of our study, but the data has not been reported yet. But at diagnosis, for the vast majority of patients with unilateral tumor, they're not amenable to a renal sparing approach. After pre-op chemotherapy, the numbers of patients that can undergo partial nephrectomy, the incidence ranges from 10 to 20%. Some are pushing a little bit more than that. And I'm going to show you another slide from Dr. Cozy in Rome, and he and I have debated this issue many times over the years, but he's pretty aggressive in trying to preserve kidneys in unilateral tumor. He, over a period of 30 years, has accrued about 50 patients that he's done the nephron sparing approach. All his patients are treated according to the SIOP chemotherapy protocol. In the early years, he was doing it at about 15 to 20%. In recent years, he's pushing it to 30%. Now, what's interesting is, he's probably the only person in the world that's not reporting relapses from this aggressive approach. I'll show you the SIOP data and our limited U.S. data that doesn't really mesh with that. So the first report from SIOP was in 2003, and they found a little less than 5% of their patients with unilateral tumors were undergoing partial nephrectomy. They have very strict criteria, and they follow it very well. Their surgeons, it's a little different than the United States, because in SIOP, you go to a center, you're getting chemotherapy, and then the center refers to the surgeon who works with the oncologist and has a lot of experience. In the U.S., we got a lot of places doing surgery on these kids, so we wouldn't really have tight control over this, which probably explains the data I'll show you later. But in any event, they want stage 1, what they think would be a stage 1 tumor, so like those partials I showed you for the screening patients, that would be obvious, most likely a stage 1 with a well-defined margin. No invasion of high-risk structures, so that renal nephrometry score I showed you, you could kind of put a system in place with that to guide your choice of patients to undergo this approach. And they want to preserve most of the kidney, which is obvious. But, with their, very strict criteria, they still saw recurrences, approaching 13%. in patients that didn't have chemo, because they had some small tumors that were treated by chemo, but 4.5% with chemo. So they're seeing relapses, which Dr. Cozy has not seen. But the important thing is that overall and relapse-free survival with effective adjuvant therapy, these patients are doing just as well in terms of cancer survival. This is a more recent update from SIOP. A little larger number of patients, still a low percentage of patients that they're putting through this approach. Again, mostly small peripheral tumors, so the surgeons adhere to their protocol. But they still are seeing problems with positive margins, which has the potential for the recurrence. But again, no difference in overall survival with a larger number of patients. So we devised a study in Children's Oncology Group, AREN0534, which is now closed for the bilateral patients. But we included bilateral patients, some of the patients with diffuse hyperplastic breast, and unilateral tumors. And the data has only been reported for bilateral, so I'll just speak to that this morning. Our strategy to improve outcome, I've kind of showed you how we got to that point and why we chose this. We wanted to define duration of pre-op therapy, so we wanted it at 12 weeks. I mean, there are going to be extenuating circumstances where someone might go longer, but we had a protocol-based time for imaging and biopsy in non-responders to see where they would do. So this really was a response-based approach to see what the imaging looked like, see what the histology looked like to define our treatment. We chose a 3-drug pre-op regimen, and this was primarily chosen to avoid switching and delaying getting to surgery. But there were other reasons we chose it. We looked at the patients that were treated in NWTS, and most of them got 3 drugs anyway. We also noted some evidence that there was a higher percentage of complete necrosis with that, so we thought that would be beneficial, and it was controversial. We particularly wanted to use the SIOP response-based approach in terms of the histology post-chemotherapy, because they have risk-stratified patients and identified those who need more therapy, those who need less therapy, and we had never used that in our US-based study, so we did that here, and I think that was a very important element to our study. So our goals were to improve relapse-free survival, to increase the number of patients getting surgery early, and to prevent complete nephrectomy in more patients. So how did we do? This was published in Annals of Surgery last year. Overall survival was 94%, 4-year relapse-free survival 81%, so we exceeded our goal. 84% had surgery in at least one kidney by 12 weeks. Again, we exceeded our goal. The only thing we didn't improve upon is the retaining more kidneys. We fell short of our goal. And I think this is where, it has to do with the centers that are treating and the experience of the surgeons. I mean, I think some of us are more willing to tackle these and do partial nephrectomies than others, and I think that probably drives this a little bit. But as time goes along, more and more people will feel more comfortable doing this type of procedure. And then lastly, I just wanted to mention, we have looked at, in a very sketchy way, those patients that are undergoing partial nephrectomy off protocol, because data gets reported to our classification study, even though they're not on study for other COG studies. And they reported this at SIOP a few years ago, that about 40 patients underwent a partial nephrectomy off study. And the tumor sizes were smaller, but not terribly small. 700 grams is pretty good for some of these. The one thing that they noted was that the surgical technique was not being followed well, the protocol. A lot of patients didn't have lymph node sampling, so that's going to impact staging and subsequent treatment and outcomes. And then the other thing is that they had a significant number of patients with stage 3 disease, positive margins primarily, but also intraoperative tumor spill. So I think if people are going to do this, they need to do it on a study. And so we had an open study, and I think we didn't have it for the standard unilateral patients, but I think we have to think about doing that the next time around. I'm no longer on the COG renal tumor group, so I'm not sure what their plans are for the next generation of studies, but I would hope that they would not have these kind of things going on off study. They need to be controlled. So in summary, the risk of end-stage renal disease remains low for non-syndromic patients with unilateral tumors. It's not non-existent, but it's low enough that we don't need to be too aggressive with renal sparing surgery for most of those patients. We don't have good long-term data on chronic kidney disease. I think we can continue to learn more as time goes along. And then lastly, I think that for non-Wilms malignancies, we have to keep in mind if we're going to do partial nephrectomy for renal cell, we have to be sure we have a negative margin, because we don't have now effective adjuvant therapy. It's better for Wilms too to have a negative margin, but at least we see that our survival tends to still be pretty good. But it is a careful balance between preventing renal disease and achieving best survival. So we have to really be a team doing this. It's not just me or any other surgeon here, we have to talk to oncology, and we discuss this together and decide what the best approach would be. So with that, I'll take questions. Thank you. Yes, Kathy.
I just wanted to express my gratitude to Mike personally for mentoring me over the last few years since I got here. And I know I speak for all my partners that we appreciate you guys so much. Anytime you want to do and just say, can I say this to you or not?
My pleasure.
So I guess I'll ask maybe it's not controversial. So a 4-year-old child shows up today that's got a unilateral Wilms, or appears to be a unilateral Wilms that's peripheral in nature, and looks to be amenable to a partial. Is that what we should be doing?
So I would go talk to my oncology colleagues first and get their blessing. I wouldn't do it without their buy-in, because they're responsible for the treatment of the patient, really. But, if it was a lesion like I showed with those ones getting screened, I would strongly ask them to consider it. Because I think but the difference is, like with the bilaterals, we go in these big tumors, we're just shelling them out. I mean, it's in a nucleation. You look at the op reports, they all call them partial nephrectomies, but they really aren't. But on these, it's going to be a partial. You got to get a wedge, you got to get a rim of normal tissue, biopsy the bed, make sure it's negative, make sure it's a tumor that's firm enough, small enough that you're not going to rupture, so you don't want to spill. So you'd make the decision intra-op as well as from the imaging. So but you want to make sure you do a good cancer operation. It's like we had a discussion earlier. It doesn't matter whether you do open surgery or laparoscopic surgery, just do a good cancer operation. Follow all the principles and all the guidelines to get the tumor out cleanly.
I have a stupid question. When they are evaluating these patients, do they take into consideration not only the size of the tumor, but also the function, let's say like function related, like the next 3. If the next 3 are the function test is okay, do you take that into consideration despite the size of the tumor?
Yeah, so we haven't really used nuclear imaging that much to evaluate these patients. We have done in some of the bilaterals if they've had treatment, and we're trying to decide if it's worth salvaging or not, but it's used very limited.
So another question. In one slide you showed that the benefit of partial nephrectomy may be a decreased risk in hypertension. And maybe this is my misunderstanding, but when you do a partial nephrectomy, you affect the blood flow. You don't know how you're controlling blood flow through the loop. It would seem to me that I can kind of understand the end-stage renal failure because that's a volume thing. But isn't there any risk for hypertension in that in the remaining kidney just based on hemodynamics?
Yeah, I don't think that the surgery would cause hypertension for most patients. All the older single institution studies looking at kidneys that were treated with some radiation and chemo and had a nephrectomy were really addressing what the creatinine GFR was, protein levels in the urine, and hypertension. And some of these studies were reporting significant rates of hypertension. So the thought is that you might be able to decrease hypertension if you have 1.5 kidneys left as opposed to 1 left. That's
Gotcha.
maybe Martin, you want to comment?
So you're not worried about the renin-angiotensin in the remaining kidney with regard to blood flow through the loop of Henry?
Usually not unless there's like a real emergency.
Okay.
Might have to correct ball pumps somewhat initially, but in the long run, it kind of
I'm done peppering you. with
Okay,
questions.
all right. Thank you very much.